I think Grace said something that's very important, which is migraine's a threshold phenomenon. And I think that's what people inherit. And when you look at the triggers of migraine, the triggers of migraine are really mundane triggers. I mean, they're really nothing special. You should get a headache if you have a gallon of Chianti. You shouldn't get a headache if you have a glass of red wine.
Correct.
And if you can't have a period without a terrible headache, or you can't have a glass of champagne without a terrible headache, you probably have migraines.
How often do you experience in taking care of somebody or evaluating somebody that pain may be there, but one of the non-painful symptoms may predominate?
Right, right.
Nausea or another symptom that just is the more disabling or impairing feature.
Right, we see that I see that a lot. Sometimes patients say the nausea in particular is much more disabling than even the pain itself.
And I think what makes us feel better, besides a normal exam, which is obviously important, is to look at recurrence. In other words, you don't get a brain tumor once a month with your period, and you don't get a brain tumor every time you have a glass of red wine. And I think patients begin to appreciate over time that it's the periodic recurring nature of this problem that makes it at least benign in terms of it being migraine.
I also want to mention that the guidelines are just that, guidelines. And sometimes people take it as it's carved in stone, and I think some migraine patients are missed by if they're going strictly by the guidelines.
You also want to make sure that the preventive drug you use is compatible with the acute drug you're going to use, because there are some issues where they're not compatible.
So can you give an example of an incompatible situation?
So you have to figure out what symptom is worse for the patient. So if the migraine pain itself is worse, or is the nausea and vomiting more disabling to the patient. So you want to individualize it depending on what symptom is predominant.
Many of the advances in therapy aren't just new molecules, but new delivery systems. And I think that becomes very important. We spoke about the problem of pills being relatively ineffective in someone who has significant gastric stasis, often accompanying nausea and vomiting. But for example, there's an improved transdermal sumatriptan, and then as Dr. Forde spoke about, there are intranasal forms and one injectable triptan. But pills are not going to be a reasonable therapy for someone who has early nausea and vomiting in their attack.
The other thing that I emphasize my patients do is to take the medications early. I advise patients routinely do not wait until the headache is rip-roaring, when they're nauseated, vomiting, and they have a lot of sensitivity, allodynia, to take the medication. Because even though the medication might work, it is much less effective.